very warm welcome to everyone who's joining in for our 8th Medical Humanities Colloquium. We've been running this seminar series for the last couple of years in IIT Gandhinagar, Humanities and Social Sciences. And it's wonderful that we have a speaker talking about medical history today, something that we haven't ventured into so far in this particular series. We've had discussions about art, theater, photography, literature, and how various humanities disciplines can contribute to the construction of a diverse and colorful, in a way, medical culture. And history, and especially the history of cancer, as would contribute a lot to our conversations today. And it's wonderful to have Professor Carsten Timmermann from University of Manchester, who will be giving our 8th Medical Humanities Colloquium. And this is Orko Chattopadhyay. I'll switch off from now and I'll hand it over to Swati Joshi, who is a co-organizer of this seminar series. And Swati, if you could please introduce Carsten and we'll take it from there. Thank you so much.
Thank you so much.
Hello, everyone. Thank you, Carsten. We're really delighted to have you. I'll just give a brief introduction that you've shared with us. So Carsten Timmermann is a historian of 19th and 20th century medicine and biomedical science at the University of Manchester. He has published on the history of concerns with high blood pressure as a risk factor, the history of lung cancer, the history of cancer chemotherapy, and more recently, also aspects in the history of psychiatry. So over to you, Carsten. Thank you so much for joining, consenting to share your ideas and the history of cancer. Thank you so much. Over to you.
Thanks very much. Thanks for the invitation. And as I said, I've been thinking about this talk as directed for a broad medical humanities audience with very little previous insight to the history of cancer and to the question why one would want to write the history of cancer in the first place. So this is very general. This is very general on how and why one might do and write the history of a disease that has been very central to our imagination of what modern biomedicine is about and how central it is to the 20th century. So, and I've been working on this for nearly 2 decades now, which is shocking. It feels like yesterday. So I'm going to talk about old work, not about new work, but trying to put it into a broader context and question it in different ways than I've done in the past. Let me share my screen. Can you see the screen? Am I sharing? Excellent. So what I want to start with, and again, narratives have been very central to the history of medical humanities, engagement with narratives, with fictional narratives, but also with stories that we might want to think of as master narratives. And while historians, or critical historians, social historians, that is kind of the tribe of historians that I feel I belong to, have been addressing master narratives for years and decades, master narratives are very much alive. As anybody who teaches undergraduates, especially science undergraduate students, but also humanities undergraduate students in the history of science will confirm, these narratives pop up again and again. That's what students believe biomedicine is about. And rather than abstractly talking about these master narratives, I thought I'd show you one, a very short one, a video produced by the UK cancer charity Cancer Research UK and available on YouTube, which is an interesting little story bringing together the story of a patient with a narrative about cancer research. And it's in a nutshell, the kind of stories that we respond to and that we deal with in teaching, but also in writing our histories. So I'll start this now, and now with sound.
Yep,
excellent.
perfect.
Mostly music anyway, so it's
One day, everyone will beat cancer. And the sooner you give, the sooner that day will come.
If you are struggling to lose weight and you're over 35,
we don't want, that's not what we want. That's always the risk of using YouTube. The ad comes right next. So you can see why, you can hopefully see why I think this is a really, I mean, it's a very well produced clip for Cancer Research UK. And it's really quite cunning how the personal narrative is combined, told together with this story of, let's just recap it. Obviously, I've prepared for this. Let's, oh, no, not watch it again. That's not what I want. I want the next slide. Let's recap what's happening here. We see a story of a life. A child grows up into a woman. Then we see cells divide at various points from the start, from conception. We see cells dividing. And this is interspersed with scenes from, obviously, from a science institute. We'll see this guy with a bow tie who looks like a scientist. He couldn't be anything else. Lecturing here. We see more scenes from the woman's life. She's launching, she's having a family, there are children, and then black cells appear. And we also see pain, we see symptoms appearing, we see more black cells appearing, we also see black clouds appearing, and then we witness what looks like a kind of diagnostic setup. She's in an oncology institute, clearly being diagnosed. There are more black cells. And then we see several scenes of scientists working day and night. And then there's a eureka moment. Our elderly white-haired scientist looking down a microscope, obviously finding something, walking down the, I should have had a, I mean, he's walking, you remember, he walks down the stairwells in the institute, and then there is another clinical encounter, a smile on her face, the cure is there, and then finally the promise, well, the invitation to donate money, and the promise that if we just invest enough money into funding science, not only will we beat cancer theoretically and as a phenomenon, but we also will help every individual patient. And the message with this is, if we fail to save a patient, we simply don't understand the problem sufficiently well. This is essentially an engineering approach to life. We just need to understand the plumbing of the human body. And in order to understand the plumbing of the human body, we need to spend more money on research. And that research follows a pattern for which the foundation have been laid in the 19th century, in the early 19th century, with an increasingly targeted attempt to identify specific causes of illness, specific local causes of illness, or specifically specific causes based in function, in organ functions. And by now, this is taken down to the molecular level. But still, we have this idea of local lesions, and in cancer, local lesions can be addressed with surgery, or of functional issues, which in research we tackle with experimental physiology, and which in therapy we tackle with chemotherapy. So the general assumption here is, if we just understand how cancer works, well, first, if we can identify its location, we can cut it out. And if we understand how it works, we can throw spanners into the works, so make it stop growing and interfere with its function. And that is, in a nutshell, still how cancer therapy works. And the why does it go wrong? This free meeting will end in 10 minutes, I'm being told.
That's strange. It should not be like that.
Otherwise, yeah, let's just get on with it, and then otherwise, we can launch another meeting.
Sure.
So this is the master narrative, as it were. That's the master narrative of biomedicine generally. If we understand it, we can tackle it, but specifically for cancer as well. But of course, not everybody survives cancer. So what are the alternative narratives? And this is where we as medical humanists, as historians, but also more broadly as medical humanists come in. And there are alternatives narratives. There are a lot more now than when I started to look at this. To start with, there are cancer memoirs, and by now there are quite a lot. When I started looking at it, there was essentially John Diamond's book. John Diamond was a British journalist and columnist, newspaper columnist, known to many Brits as the husband of Nigella Lawson, who is a famous television cook, and John Diamond was her husband. And he was a heavy smoker, and he developed a esophageal, I can't pronounce, esophageal cancer of the esophagus. And this is an excellent book telling his story, his trajectory through, reproducing his trajectory through the British Health Service, but also his personal reflections on having cancer and being treated for cancer. He died from it, and the book, initially published as newspaper columns, is a very touching and still very insightful account of his trajectory. Similarly, I could show lots of them, and I've had students looking at whole series and trying to make sense of them and analyze them. This is another very good one, Dina Rabinovich's Take Off Your Party Dress. Again, another book that started as a newspaper column and then was turned into a book. And there's the memorable line in there when she proposes this to one book publisher, and they said, "Oh, the cancer memoir market is the crowded market by now." So she had problems to place it when she tried to place it. That was published in 2007 already. By now there are lots more. But not everybody who writes. Rabinovich also succumbed to her cancer. She also died. Susan Gubar is another interesting author. She is a literary scholar, and she writes about her experience with ovarian cancer. This was published in 2012, and this is a very, Swati, you have to look at that book. It's a very literary engagement with the subject. And there's one more I want to show, but there's lots of them, which is very different. This is a graphic novel on breast cancer experiences, again by a woman who survived breast cancer experience, Marissa Marchetto, a cartoonist who published this book, A True Story, Cancer Vixen, in 2009. But this is just a selection of alternative narratives. Now, these are not the type of alternative narratives I want to engage with because I'm a historian, so I'll point you to some others. This one may be the one that's familiar to most of you, Siddhartha Mukherjee's book, which turned into a bestseller and won an award, published in 2010, won the award, the Pulitzer Prize for Nonfiction in 2011, which is an interesting book, but it is quite close to the master narrative, although Mukherjee uses a lot of, and he uses them extensively, a lot of other cancer histories, professional historians. And the book is an interesting, again, merger of these historical accounts with personal accounts. Mukherjee himself is an oncologist, so he very much believes in the progress, and he intersperses the historical reflections, historical episodes in the history of beating cancer with accounts of his personal experiences in his practice. Okay, so there's Mukherjee's book, but that's actually quite late already. I'll just go through the first one I encountered, and that every other cancer historian will have encountered, is Patterson's Dread Disease, which places the history of cancer in general American history since the 19th century. And that's what the subtitle says, Cancer and Modern American Culture. It's very interesting, but it's not the approach I would take as a historian of science and medicine. Then another book that was already published when I started working on this is Baron Lerner's The Breast Cancer Wars, specifically looking at breast cancer. Breast cancer is one of the cancers, as we will see, that's but there's actually been quite a lot of progress. And again, what Lerner does here is he unpacks how activism, and you can see activism here on the title, activism around breast cancer mapped onto American culture after the Second World War, and especially he looks at the response to the radical, well, the radical mastectomy as the key therapeutic intervention, and the activist response to the radical mastectomy, but also the pink ribbon movement. So excellent book on breast cancer. A slightly different approach on breast cancer comes from Robert Aronowitz. Here, breast, again, he engages with the question in how far the treatment, the intervention, turns the natural history of disease into an unnatural history, into something new, which we then again have to respond to in a variety of ways. Then how cancer crossed the color line, again deals with a specific issue, uses cancer as a vehicle, an analytical vehicle to look at the different treatment that Black Americans, African Americans have been receiving, specifically for cancer here. Keating and Cambrosio is a very history of science approach. It looks again at cancer, but to find out something slightly differently. It's interested in styles of practice, and there especially the key role that clinical trials have had, randomized clinical trials in post-Second World War medicine, and the pioneering place that cancer clinical trials, with all the funding they've been receiving, have played in this. Scheffler, a very recent book, excellent, has been, there's overlaps between Scheffler's and Keating and Cambrosio's books in that they both are very interested in stuff that's been happening at the National Institutes of Health, at the National Cancer Institute, which is a function. If we think about how historians work, you work where the sources are, and public archive, public records will have to be maintained. So public records are much easier to, well, they're not always easy to work with, but at least there is a body of records that can be used. So we have good accounts of what's going on in the Medical Research Council, because those are in the UK. Those are public records, but we also have good accounts of what's happening at the National Cancer Institute, which admittedly was a key place for studying cancer and understanding cancer for basic research, but also, as Keating and Cambrosio develop clinical research. Really, the randomized clinical trial is one of the ways in which the standards of the laboratory are being expanded to the clinic. And then more recently, a book that I've reviewed, Agnes Arnold Foster's book on the cancer problem, which looks at malignancy in 19th century Britain. I've said that cancer is often seen as a disease that has defined the 20th century. And what Agnes is doing is saying, well, if you look closely, you find it in the 19th century. There's already a clue to how we work as historians, and I'll talk about that before I come to my own work. Closer to my own work is this book, N. Barnes Johnston's Changing Faces of Childhood Cancer, which deals with a specific set of diseases, which specifically childhood cancers. And what you can see if you look at, I mean, I've given you a chronological account here, and you can see more and more specific questions. Patterson, well, Mukherjee is the odd one out, but he's the book that's for a general audience. All the other books are for are scholarly books, scholarly monographs, more or less. And what we find is that they deal with more and more specific questions. They start quite generally when there isn't anything from professional historians. All there is are the biomedical master narratives and the insider histories from people involved in those stories. And then we get professional historians from the 70s and 80s looking at these issues. And what do they do? What do we do as historians? How do we approach these things? And a common approach in the history of medicine and the history of science is to take up a constellation that's generally taken for granted, set of developments, a constellation, a narrative that is taken for granted, and we start picking holes into it. We make it look strange, not as obvious. We point out that where we are today is not the outcome of inevitable progress. You know, that biomedical master narrative has a certain notion of inevitability to it. That's progress. You can't turn back the clock of progress. What we as historians say is, it's always more complicated. That's a typical sentence that you will hear from historians. You think that a development was obvious? Think again. What if I tell you that it was all much more complicated than you think? And that's what we find here. Every new history picks holes into older ones, because what we do is although history arguably is less reductionist than other approaches, still what we have to do is a set of very complex, reduce a set of very complex constellations and developments and interactions and turn it into a linear narrative, into language, into something. So we order, we leave out, we decide what we put in. So there's always something that people leave out, and if you come later, you pick up these histories and you look at them and you think, this doesn't make sense. There's a hole I can dig into, and that's in fact what Agnes did with my book. I glossed over the 19th century because that wasn't my main focus. So she says, look, there's a lot more than people like Timmermann see. And she pointed out that, you don't have to dig that too hard to see that the history of cancer is not just a 20th century history. You can tell a 19th century history of cancer. But I have M. Barnes as she was, and M. Johnston as she became later. I have M's book here because that was part of the collaborative project that I was involved with. We had a big grant we applied for in 2003 to write collaborative histories of not cancer, as Patterson did, but of several cancers. And to do so from different points of view. So we identified a few holes in the standard stories and tried to kind of broaden them out and explore them. And so explore different cancers with different issues in mind, which we thought can be explored profitably. So my own book, which I just kind of want to look at very, very briefly now. It's not a new book, but I thought for this talk I can kind of pick it up again, was a history of lung cancer. The publisher wanted us to have the history of lung cancer as the top title. as the main title, but what it really, what I've tried to do is explore the phenomenon of recalcitrance. And I've kind of hinted at that when I talked about the Cancer Research UK narrative, because there's the standard narrative, and clearly it works for some cancers, but it doesn't work for all. It doesn't work in many individual cases, and we'll have the cancer memoirs to look at what happens in these individual cases, but we can also look at diseases where it doesn't work. And lung cancer, we've argued, is one where the kind of general assumptions don't work. Let's have a look at what I mean. This is a very nice diagram from it's fairly brief, fairly recent for a historian, only from, when is it, like 2011, so it's almost yesterday, about plotting survival times. Usually we think about cancer mortalities, but in this case, it's a plot of survival times after diagnosis. And that's in many ways a more insightful parameter if you want to understand the success of interventions, because you have a diagnosis and then you apply the repertoire of interventions to this case, and then you see how long people survive after diagnosis. And you can see, and that would be a good measure for the success of biomedicine, of that biomedical model, if you want. We can see here that for some, and that's what Macmillan in fact say, for some cancers, there have been dramatic improvement. I mean, especially for breast cancer, if you just look at this, it started off with reasonably good prospects for patients to survive for a long period after diagnosis, and it's gotten a lot better. But there are also others where this has been good and promising, and those are the ones that are shown here. But then there are others where there have been very, very little improvement, and that includes lung cancer. There's almost no change here in the 30 years, or nearly 40 years from the beginning of the 1970s. So clearly, and I thought recalcitrance is a good way of looking, of conceptualizing this. Clearly, this disease has been resisting any attempts to control it in the ways that have worked for other forms of cancer. So this is where you get, if you. So the proposal here is to write to write more finely grained histories of specific cancers. So how to approach this? There's this thing which, again, historians of medicine will have encountered this. This is kind of published in a formative period for the critical history of medicine. It's from a book by a professor of social medicine, Thomas McEwen, published in the 1970s and what he was interested in. I mean, it comes from this kind of general background of critical attitudes towards the claims of modern medicine that emerged in the 60s and expanded in the 70s, critical of established authorities, and also the background to new approaches in medical humanities more broadly. And the attempt here is to, and that's McEwen's argument, the attempt here is to show that the interventions proposed by biomedicine made very little difference for the to kind of survival, mortality figures really here, death rates for tuberculosis. So he plots the main interventions onto the mortality figures here. And so this is then what I've looked at for lung cancer in principle. So let's have a look at this. Let's have a look at the history. So I've been looking at, to start with, the conceptualization. When does lung cancer become a thing? What you're seeing here is, I don't know what, if we were in a seminar room, I would ask you whether you know what we're seeing here. Does anybody know? I can't actually see whether you answer, so I'm not going to, although you can obviously unmute yourself and throw an answer into the Zoom room. What are we seeing here? What's this thing? Nobody knows? That's a stethoscope. So that's a stethoscope as it was developed by René Laennec, French post-revolutionary doctor in the early 19th century. And the first sight of this story is the emergence of modern biomedicine, as it were, in post-revolutionary France. Well, actually, it emerged in other parts of Europe as well, around the idea of pathological anatomy, around the idea that to start with, you could very systematically note clinical observations, but then also if your patients happen to die in your care, you could do an autopsy and you could see whether in the post-mortem what you found in the organs you suspect to be involved corresponds to the clinical symptoms. What you see here, I mean, you see the stethoscope here, and you see lungs here. So the next step then is to develop diagnostic tools that allow you to see things you suspect are going on in the lungs and in other organs before death, and that's exactly what the stethoscope is. The stethoscope is a scope. You're supposed to see with it, but you see with your ears, really. You learn, that's the argument of those introducing these instruments. You learn to hear structures in the lungs. Why am I telling you this? Because that's the origin of lots of new disease concepts, and among other things, it's what turns one form of consumption into tuberculosis, because tuberculosis is a disease that is marked by tubercles, by these little lesions in the lung. So it's no longer consumptions, a condition where you decline slowly, made sense of in terms of humoral pathology. It's something that's linked to these lesions. And that is also the time when lung cancer gets kind of conceptualized, not as, well, sometimes as cancer, but also more commonly as a different type of strange growth, a neoplasm, a new growth. So you have new growths, tubercles, but you have other forms of new growths that are not tubercles, but that are also linked to illness. And that's where lung cancer emerges. Or here you have something of the context. You have an autopsy being undertaken and students looking on. And here's a scene where René Laennec uses, well, actually he doesn't use the stethoscope, which is a bit upsetting. He's just holding the stethoscope here and listening to one of his patients' chests. So that's when lung cancer emerges as an entity, because you can only at that point identify it after death, because in autopsy it's one of several forms of consumption where people decline and die, and with respiratory problems, and then only after death you can identify it, and that happens more and more frequently, but still very, very rarely. There are not that many cases of lung cancer in the whole 19th century. In the 1850s, 1860s, we have this man Virchow proposing a new way of making sense of the kinds of new growths. So that's when these new growths become something specific and different from other types of new growths. This is the father. Virchow is the father of cellular pathology, cellular pathology, the proposal that all life process, but also all pathological processes can be explained as interactions between cells, and cancer then becomes what we still think it is, cells out of control, cells that somehow stop behaving like good citizens of a cell state. And cell state is the metaphor that Virchow himself used. So this is the birth of cancer, as cells out of control. Now, I've talked about the fundamental idea of biomedicine being that each of these new findings also has to lead to new interventions, and the intervention that grows out of cellular pathology is the new scientific surgery. That we've mentioned briefly when I talked about Lerner. I mentioned the radical mastectomy, and an intervention developed by an American surgeon. Is it William Halsted? I think it is. This Halsted conceived of this operation as an application of cell theory. He followed the cells and decided to, plan the operations so that all the cells that could potentially, based on his observations and the observations of others, become cancerous, will be taken out. So a very radical operation based on cell theory. For lung cancer, well, this was a bit more difficult because taking internal organs out is always a different challenge. So in the book, I'll talk about the practical challenges there. The man hailed with introducing radical lung cancer surgery is this American surgeon, Evarts Graham, who is credited with the first pneumonectomy of removal of a lung in 1933. So this is the attempt to apply what has worked in breast cancer to lung cancer. Radiotherapy doesn't work. Radiotherapy is the other new intervention which gets introduced, developed in the interwar period and further in the post-Second World War period, isn't working that well for lung cancer at that point. But surgery is promising. The thing is, though, that lung cancer at that point, so it's Graham is celebrated for this in retrospect, because lung cancer until then doesn't seem to be that much of a problem. There doesn't seem to be that many cases, not many cases get reported, but it's a growing number. There's a growing sensitivity to diagnosing lung cancer. And this is again, well, I have to remind you, it's not obvious. You only know after a post-mortem whether somebody died from lung cancer or from another respiratory problem, and not that many people people who died in hospital undergo post-mortem examinations at that point, and let alone if people die at home, they don't register as lung cancer patients. Only once there is a debate about it, and there is a consciousness that this is something that seems to be happening more frequently, this diagnosis becomes an option for doctors, but also for epidemiologists, policymakers. And this really becomes an issue in the post-war period. And this is a report indicating that by then it had been a problem. This is a report published by the Royal College of Physicians here in England, of the Royal College of Physicians of London, I think is the full name, and a report on smoking and health published in 1962, which kind of summarizes, compiles a lot of the evidence against smoking, and then in retrospect also identifies an increase in, the emergence of this as a problem. You can see here, you see death rates for middle-aged men here, which is the main risk group for lung cancer from smoking. And there you can see that tuberculosis, increasingly no longer a problem. That resonates with what we've seen from McEwen earlier. Also, other cancers seem to be declining, but lung cancer seems to be going up. But, again, we have to take this with a pinch of salt, because conclusively here, we can only tell whether somebody died from lung cancer if they, in fact, underwent autopsies. But there seems to be something going on, and there's growing concern. There's growing concern with smoking. The Medical Research Council in Britain funds epidemiological research, which becomes very iconic for its innovative use of epidemiology, and it's copied for all sorts of other things. And this type of research, this research identifies smoking as a cause of lung cancer and of lots of other things. And you can see this is a headline from the cover of a major tabloid paper in Britain. And so this is a very publicly discussed issue. And a survey undertaken in Edinburgh, in fact, in 1958, which was designed to evaluate the success of an education campaign against smoking, found that 98% of the people interviewed had heard about the link between smoking and lung cancer, even before the start of the campaign. So this was very common knowledge. People knew and assumed that that smoking caused lung cancer. So very high degree of public awareness. Oh, why do I have him here? This is King George VI. He died from lung cancer. So again, this is kind of, and he was a heavy smoker. So this is in the 1950s, really is in people's minds. So far, this really is a story of progress. If we stopped here, we could say this is quite successful. We have an intervention. It's too early to say whether it's any good, but we now have developed lung surgery, radical lung cancer surgery as a routine intervention. We have some really groundbreaking epidemiological research which identifies the main cause of lung cancer. This is quite successful. However, it turns out that that's where things stall and people become quite gloomy. Here we see these are all chest surgeons, so specialist lung surgeons who are trained to work with tuberculosis, but increasingly were turning their attention either to heart disease or to lung cancer. And if you look at the proceedings of this meeting, you find very, very frustrated and depressed chest surgeons who think that they can do interventions. They find they can do these interventions, but it doesn't seem to make a difference. The results of the treatment are so poor, whether by surgery or radical radiotherapy, that there's an urgent need for further research to improve the treatment of this condition. There's also an urgent need to apply the knowledge already available, in particular that of the role of the cigarette smoking to the prevention of the disease. So what's happening here is that these people who should be keen to intervene want to leave lung cancer because it's too depressing. The results are too depressing. So they either, most of them turn to, I mean, they still have to do lung operations, but for things they find exciting, they turn to heart surgery here. And they say, okay, if we want to make a difference, we need more basic research. So Cancer Research UK type stuff, or we just need to look to prevention. And that's where attention turns then as well. There continue to be trials. So that the other big new thing is randomized clinical trials, and that we do find randomized clinical trials funded by the MRC, but again, nothing works really well. It's all very disappointing. So this is where my notion of recalcitrance comes to play here. This is nothing really works. The disease seems to resist what works for other malignant disease. So what could be done? What we find is that there's increasingly more public attention to prevention, and anti-smoking campaigners take a new strategy. There's the attempt to actually stigmatize smoking, to make it look like it's about delinquency, or that it is what you're doing is you properly harm the fetus or other people around you. So smoking becomes a delinquent habit, which was a very normal habit in the 1950s. It becomes something that's associated with delinquency. I'm not saying that this is wrong. I think there's a logic to it. I'm just saying, and going back to what I started with, we shouldn't take it for granted. This changed attitudes towards smoking is an outcome of contingency. Okay, so I'm coming to the close now. I think I've given you a sort of insight to what I tried to do and what motivated me. And this takes us back to this year. This all explains to me this difference, this discrepancy between what we find for some cancers and for others, but it explains it historically, and it allows us to work out what it means for patients, but also what it means for practitioners who deal with lung cancer. So to conclude, where does this leave us as medical humanists and specifically as historians? Writing and rewriting history, I would like to propose, is about making new sense of past developments for a new present, because obviously our present changes. Attitudes to smoking today are very different from attitudes to smoking in the 1950s. For example, it's about creating space for alternative narratives, about asking questions, about looking for meaning behind the obvious. And it's also about looking for what could have been alternatives, not only for what has been. So it's about opening alternative spaces. And that's, I think, where I'll leave it. Stop sharing here.
But thank you so much for doing this for us. Thank you so much.
Thank you. Thanks very much.
Bye-bye. Bye, everyone.
See you. Bye-bye.